Good afternoon, everyone. My name is Maryam Adnan Hadi, PharmD student in Baghdad College of Pharmacy. In this seminar today, we will be discussing a recent study about semaglutide effect on BED, which is the binge eating disorder. Discussion: the present open-label retrospective cohort study evaluated the effects of semaglutide on binge eating symptoms in patients with moderate to severe levels of binge eating. Open-label retrospective cohort study is a type of observational study used to investigate the effectiveness of a particular treatment or intervention. In open-label study, both the researchers and the participants are aware of the treatment or the intervention being administered. This is the opposite thing in the blinded study, where both parties are unaware. In the retrospective cohort study, we're looking for data from past. Alright, as a quick recap for the results of this study, treatment with semaglutide resulted in significantly greater reduction in the binge eating scale scores compared to those receiving lisdexamfetamine and topiramate, two common anti-obesity medications used to treat the binge eating disorder. The group with combined pharmacotherapy with both semaglutide and other anti-obesity medication did not result in greater reductions in the binge eating scale score compared to the semaglutide-only group. This study was not the first one in eating disorders. Instead, previous studies done on the GLP-1 agonist, which is the glucagon peptide receptor agonist drugs, for eating disorders also were surprisingly effective. For example, a study by Porto and colleagues found that treatment with the glucagon-like peptide 1 analog, dulaglutide, was associated with a greater reduction in the PS scores relative to glycoside or sulfonylurea compound that increases insulin but is not known to affect the brain reward circuitry or appetite. Additionally, a short-term 3-month pilot study of liraglutide by Robert et al. Has shown promise in reducing the binge eating disorder symptoms. A pilot study means like small-scale preliminary study conducted to evaluate the feasibility and the potential of larger research projects. The present findings thus make the important contribution of providing the first evidence in humans that glucagon-like peptide 1 analog semaglutide may be effective in reducing binge eating symptomatology, and possibly more effective than other commonly prescribed medications known to alter the reward neurocircuitry and appetite behaviors. This study has implication for neuroscientists on the mechanism behind the effect of a glucagon-like peptide 1 receptor agonist on binge eating disorder, because in the CNS we have two pathways rich in glucagon-like peptide 1 receptors, which is the mesolimbic dopamine pathway and in the subnuclein 19 in the hypothalamus. And the extensive preclinical research demonstrate that GLP-1 analogs, such as the semaglutide, have their effects on the eating behavior primarily through modulation of these central nervous system targets. For more understanding, this figure illustrates these pathways. And here we can see these neurons and how they containing the glucagon-like peptide 1 receptor. Finally, by understanding the specific neuronal pathways involved in the effectiveness of the GLP-1 agonists, researchers can develop more targeted and effective treatments for this disorder. In this study, we expect that the reductions in the binge eating symptomatology observed here likely arise from semaglutide effects on the CNS circuits, but further research is needed to determine the precise mechanism by which the GLP-1 agonists reduce binge eating symptoms. Also, future studies should investigate the optimal dosing and duration of treatment with semaglutide, as well as potential interactions with other medications commonly prescribed for the binge eating disorder and/or obesity. In conclusion, binge eating disorder is a common psychiatric condition that can affect cardiovascular mortality of patients with obesity, with limited current treatment options. The findings from this study provide rationale for future randomized clinical trials to assess the efficacy and safety of semaglutide in the treatment of BED. Overall, the present study adds to the growing body of evidence supporting the use of GLP-1 agonists, including semaglutide in the treatment of BED. Semaglutide may be a promising pharmacological treatment option for patients with moderate to severe BED, and further research is needed to elucidate the mechanism underlying the therapeutic effects. The promising results and significant outcome of this study does not mean it's without limitation. One of the main limitations in this study is the limited sample size, which may limit the generalizability of the findings to larger groups, larger populations. This means that the study may not be representative of the entire population and its finding cannot be applied to everyone. Another limitation is the lack of randomization, which may introduce bias and affect the validity of the results. This means that if the participants were not randomly selected, there may be a certain bias in the study that could affect the accuracy of the results. Lastly, the study does not provide information on the potential confounding factors that may have influenced the outcomes, such as the participants' comorbidities or concurrent medications. This makes us wondering it could be other factors that may have affected the outcomes of the study, and without this information, it is difficult to draw accurate conclusions. While the study found that both treatments resulted in significant improvements in BED symptoms, it is important to consider other possible factors that could have influenced the results. One explanation could be that the observed differences in the PSS scores between treatment groups could be due to sampling variability in age and ethnicity. It is very clear how the differences in these groups are different in number. For example, in the SEMA-only group, the white people are only 15, while with SEMA and other anti-obesity medication are only 5. While 9 in the only obesity medication. As I mentioned before, confounding variabilities that were not accounted for in this analysis, factors such as comorbidities could potentially influence the change in the PSS score. Another explanation that it could be attributed to the placebo effects. Participants in the SEMA-only and SEMA-only anti-obesity medication groups may have experienced a greater improvement in the PSS scores simply due to their belief in the effectiveness of the new medication, rather than any specific therapeutic effect of the interventions. Lastly, it is important to consider the possibility of measurement error or bias in the assessment of the PSS scores. Thank you for listening.